Good afternoon, everybody. It's my pleasure to have with us today Sir Cunningham. He's a professor of pathology at the University of Cunningham Medical School and the Royal Free Hospital, and an honorary fellow of Trinity Hall, University of Cambridge, both in the UK. His early training was in Cambridge, preclinical, and Oxford, UK clinical, with postgraduate training at the University of London and Washington University School of Medicine, USA. And Sir Cunningham was physician to HM Queen and was one of his services to take care of the royal family since 2015. Academically, Professor Cunningham had run research programs examining the following control by structurally modified vitamin D, metabolites, pH synthesis and release, the synthesis and release of bone cytokines by osteoblast-like cells, the location and relevance of the calcium sensing receptor in bone cells, the influence of simulated uremia on the release of cytokines by bone cells, the factor mediating bone loss following renal transplantation, and the preventive strategies, the factors that improve arterial function in people, including the vitamin D metabolites and calcium-mimetic agents. His group also devised, conducted, and published studies of the first effective prophylaxis against bone loss in the post-transplant setting. On these and other subjects, Professor Cunningham frequently lectures nationally and internationally, as well as serving on numerous international expert panels and working group. He is a founding co-chairman of the Nephrology and the Limits series held under the auspices of University College of London, University of Cape Town, and Lancet, and I have the honor to attend 2 of them. And he has published more than 12 original articles in the scientific journals. This is why we have the great pleasure and honor to have Sir Cunningham with us today. And the program, he will give us a presentation about the cardiovascular complications in the domain of CKD, and he gives some clues about myocardial infarction, and will be followed by discussion of cases. Before I leave the stage for the chairpersons, I want just to thank Amgen Egypt, Amgen Middle East for this exhaustive efforts in Cairo and here in Mansoura and tomorrow in Cairo. Thank you very much for all these activities and sponsorship of these activities. Dr. Ayman.
It's my honor to present Professor Cunningham, who's going to start with a lecture about the cardiovascular complication of CKD-MBD. Please, sir.
لسه مش عارفين والله الناس.
So my second visit to this city and to this very impressive medical centre, which I have to say I find quite amazing. To learn that you have 270 nephrourology beds in a single institution is quite remarkable. It's remarkable for any country, and I think it may well be the biggest centre of its kind in the whole world. Certainly bigger than anything we have in the UK. And we've got some quite big centres too. So it's a great privilege to find myself here again. I've enjoyed my trips to Egypt enormously in the past, being beneficiary of your hospitality, generous kindness I received from colleagues here. So it's an enormous pleasure to me, and I'm also very grateful, I must say, to Amgen for allowing this to happen and for me to speak to you. Now, some of you heard what I said yesterday in Cairo, and there'll be a little bit of overlap between the content of today's talk and what I said yesterday, but hopefully not too much. And we're going to talk about cardiovascular complications of CKD, MBD, but we're also going to divert a little beyond that conventional area and talk a bit about myocardial infarction in the context of CKD, and touch very briefly on cardiorenal syndromes as well. But the main focus of the talk is going to be in the CKD-MBD territory. So this is the disease that we are talking about. And this is what it does to people. The mortality rate, as we know from CKD, end-stage on dialysis is extraordinarily high, and mainly cardiovascular. And you can see here that the whole of the right side this diagram here, all this relates to cardiovascular disease, so something in the order of 50%. These data are taken from a study called the 4D study, which you may remember was a study in diabetics on dialysis, conducted to look at the effect of statin treatment on lipids. Incidentally, that study was negative, showed no effect of treatment, but that's another story. So you can see that cardiovascular disease is a major cause of demise here. And in the early years, when I was getting involved in academic nephrology, and very much focusing on metabolic bone disease in nephrology, we didn't think about the circulation at all, not in the context of metabolic bone disease anyhow. So this coming together, which is reflected also in the name, CKD-MBD, is something that is relatively recent over the last 10 to 20 years, and certainly not prior to that. Now, I think it's worth just considering the heart and the kidney briefly. There are certain similarities here, and I said, are they cut from the same cloth? Now, we're talking about two visceral organs, and they both occupy critically important positions in the circulation. They're both very closely involved in the regulation of volume and blood pressure. And there is a high degree of interdependence between the two, such that if something happens to one of them, there are knock-on effects on the other. And furthermore, very often those effects tend to have a multiplier type consequence, so that the impact of, say, kidney disease on the heart is very often greater than one might expect, and vice versa. The other thing that they have in common is they both are very, very metabolically intensive. Renal blood flow is 500 mils per minute per kidney. The heart takes about 400 mils per minute at rest. So these are both highly vascular and very demanding organs in terms of the work they do. The kidney, of course, is doing metabolic work. Now then, a word about how we're going to go through this talk. We're going to talk a little bit about the epidemiology. We're then going to talk about CKD-MBD, talk about vascular calcification and arterial stiffness, and we'll then talk a bit about some of the hormones, and particularly some that are deficient, vitamin D and both native and active forms, and some that are present in excess, PTH and FGF23, the main ones. Then we'll talk about acute myocardial infarction and cardiorenal syndrome. This figure is something that you all have seen many times. You could probably draw this in your sleep, I imagine, but again, it just there to remind us just how enormous is the risk of being a dialysis patient compared with not being a dialysis patient. Age-related, age-adjusted. As you get older, the relative risk gets much less. So the dramatic difference is in the young adults here, where there is an increase in risk of around 100-fold of mortality, most of it cardiovascular. Now you know all this, and this is all very, very worrying for us. But from that, one can conclude, and indeed other data, that a dialysis patient of 25 to 34 years old has the life expectancy of a healthy 85-year-old. Now this is pretty dreadful when you think about it. And an interesting point is that, I don't know about you here, but my patients in London, most of them do not know this. And it's an interesting question as to whether they should know it. Does it do a dialysis patient at 25 any good to know that his or her life expectancy is that of an 85-year-old? It's rather like telling someone they've got cancer and they could die in 5 years, isn't it? So it's a big bit of information, but essentially most of our patients either have never been told, or if they have been told, they don't want to hear it, because it's sort of an unpleasant bit of information. Now, cardiovascular disease, I've said, is the dominant cause of death. No other single disease process gets there, and that holds essentially most of the way through the age band here. So there's all cardiac in the very light brown at the top here, and you can see that it's a dominant cause at whatever age you are. And the bottom line here is that being a dialysis patient is much more dangerous than having most types of cancer. Now, there are some cancers that are clearly worse. Lung cancer is worse. Cancer of the stomach or pancreas, that's worse. But the majority of cancers are nothing like as dangerous as being a dialysis patient. And it's interesting, I often put the question to a mixed audience like this, and I say, do you think that women out there, not female doctors, but women out there, given the choice of having kidney failure or breast cancer, which would they choose? And the answer is most women would choose kidney failure. They'd say, I don't want to have cancer. But they'd be wrong. They should choose breast cancer, always, because it's nothing like as dangerous as dialysis is. And the same applies to colon cancer, bladder cancer, prostate, kidney, cancer of the kidney, etc., etc. Most of the major cancers are a good deal less dangerous than being anemic on dialysis. Now, why is it that these patients do so badly? Well, from the point of view of someone interested in bone and mineral metabolism, these are the things that are spectacularly wrong. And these are the things that might, therefore, get involved in the drive to this early disease. And we obviously have, in the context of a low GFR, of poor excretory capacity, we have high levels of urea and creatinine, but also a lot of other things as well, some of which we know a bit about, but a lot of which we don't know very much about. So there's clearly the question of poor excretion and retention of potentially toxic substances. So there's really a black box there, in my view, and potentially all sorts of dirt circulating around in the blood of these people, mainly harmful. Some of the things there that we do know about, and we know is harmful, is phosphate, elevation of phosphate. We know that calcitriol is at very low levels in these patients, abnormally low, maybe that's bad. We know that PTH is at very high levels, that may be bad. We know that FGF23 is at even higher levels still, that may be bad. So this is not a complete list, but I just put out some of the more important and obvious examples there. Now again, many of you will see this, just showing the trajectory of what is going wrong as the patient moves from normal kidney function out on the left here across to advanced renal failure, starting dialysis. And note the enormous increase in the concentrations of PTH and FGF23 starting way back here when the GFR is still up to about 75 or so. So you don't need to lose a lot of kidney function before the first signs of an adaptive response are coming in. And because those responses are so effective in controlling phosphate, particularly the serum phosphate level doesn't change at all until you're way down around 30 or less GFR. Now, if you didn't have FGF23 or PTH, the phosphate would start rising much sooner. And that may be also a bad thing. We talked about FGF23 perhaps being a very bad thing, but if we didn't have it, we might have to have a much bigger problem with phosphate than we actually do have. So it's part of the adaptive response. And the big question really is whether at this stage, when you're on dialysis, these enormous levels are no longer adaptive, but you could call them maladaptive. They've actually become bad, having initially been quite good. But once you're on dialysis, see the advantage of rising PTH and rising FGF23 around here is it helps you to control your phosphate. But that's not an issue on dialysis because we haven't got any kidneys. So you're going to control phosphate by other means at this stage. So a high FGF23 doesn't really bring any benefit that I can see, and it may bring some harm. So this is what I mean by becoming maladaptive at this point, having potentially been beneficial and adaptive response moving on. Stick a transplanted, which is what we're always trying to do the whole time, of course, so I know you do a lot of transplanting here, and what happens, suddenly phosphate comes down at high speed, usually or very often to subnormal levels, and that's because of this residual hangover of FGF23 and PTH, which take quite a time to come back towards normal. And although they're depicted on this graph as coming back into the normal range, an awful lot of them never quite make it back to normal. So a lot of transplant patients, for example, even those with outstandingly good function, will, when you look at them carefully, have very mild persistent hyperparathyroidism. And they behave rather like patients with mild primary hyperparathyroidism. That's the phenotype that we have at that point. After you may have an excellent kidney with a good GFR, it's making calcium channel properly, it's excreting phosphate properly, but because PTH has never come quite back, it's often sits in the upper part of the normal range, you end up still with the serum calcium also sitting in the upper part of the normal range. This may not be ideal. We know it's not good for you with primary disease. Now that's essentially the issue that we're trying to confront here, isn't it? And I think it's important. I mean, it's quite useful. This one came from KD, and I think it's not a bad diagram because it does emphasise at the centre here these patient-level outcomes. That these are the things that are going to matter to the dialysis patient, the CKD patient, who by and large is not very interested in whether he's got calcification or what his FGF23 level is doing. He wants to know whether he's going to have a heart attack or a fracture or go to die. Those are the key patient-level outcomes. And these are the things, of course, that increasingly we're focusing on when we try and design clinical trials now, and which are really difficult in nephrology to identify, or at least to monitor, to identify significant changes as a result of treatments. And a good example, which was often mentioned, is the old study, which again was a highly ambitious study, incredibly expensive, a very, very brave, good move, I think, by Amgen to go and take on that challenge. And it was really difficult to demonstrate any effect of a drug that looked as though it should be really good. So this is not easy to get at. And similar difficulties have been experienced with treating lipids, with treating phosphate, with phosphate fibers, etc. So it's not easy, but we do have really these three things going on in the periphery, all of which is in fact rather easier to measure. We can measure calcification, we can measure all the laboratory stuff, and we can, perhaps slightly more difficult, assess bone disease in some ways. We do a biopsy, we're not going to do it very often, but essentially we can get a handle on those, and they all have an input to these patient-level outcomes. Now, as far as these outcomes are concerned, there's an enormous amount of information out there looking at associations between this or that variable and what happens to the patients. And this has been quite, I say, easy. Nephrology has been quite good at this because we do have big data sets on patients. We have the USRDS, we have the European Renal Association, we have DOPS, we have various groups that are collecting data on the grand scale. And those databases allow an awful lot of epidemiological analyses to be done, but they're not very good at allowing you to establish genuine cause and effect. So, for example, this is, I think, comes from the Fresenius database in the USA. So this is about 40,000 dialysis patients here. Okay? So there's a lot of patients. And it's simply looking at outcomes here, looking at relative risk of death in relation to serum phosphorus concentration, or in calcium, or in PTH. Don't worry about the product, we'll look at these three here. And the point I want to make here is that for each of these, you can see a dose-response curve. And in the case of phosphate, the dose-response curve is much steeper than it is for either calcium or PTH. We can go into a discussion about why that might be later on. But essentially, this is showing quite powerful association. This has been shown over and over again. As you know, lots of studies have shown this sort of thing. And this increase in relative risk is very substantial. This is at least a twofold increase in relative risk here at high phosphate compared with optimal phosphate. What it does not tell us is that if you take a group of patients out here on the right-hand side and you treat their hypophosphatemia really effectively, you bring their phosphate down to these levels here, but do you bring their mortality down as well? And the answer is we don't know. We have not got a clue as to whether that will achieve the predicted result here. Because the studies have either not been done or they're very difficult to do in a robust way. Just still speculating there. We hope, but we don't know. Same true with calcium, same true with PTH. This simply shows that in many of these variables that we look for associations between a bad outcome and the variable itself, we find a U-shaped curve. And this is true in a lot of medicine, not just in nephrology, of course. You can see it with blood pressure sometimes, you can see it with lipids, etc., many other areas. And in the case of phosphate here, this was actually, I think, taken from an editorial that Justin Silver and I wrote a few years ago, looking at this. But basically, this is quite a steep U here, and a low phosphate translates to a bad outcome, and a high phosphate translates to a bad outcome. This would be a range that would fit in with many of the guidelines out there, which, comfortably enough, does sit around about the bottom end of the U, fortunately. We're quite relieved about that. But down at this level here, we're probably seeing the adverse effect of comorbid conditions that are associated with poor nutrition, low phosphate, etc. Out here, we're seeing a rerun of the effect I showed on the previous slides. Now, the apparent link between these variables, calcium, phosphate, PTH, etc., and outcomes, was one of the reasons that using a drug like cinacalcet to try and probe these associations seemed very attractive. Now, the thing about cinacalcet is that when it came along, it was the first time we had the ability to maneuver calcium and phosphorus simultaneously, and indeed PTH, all of them in a direction that we would expect to bring with it an improved outcome. So by and large, the sort of patients who are put onto a drug like cinacalcet, and the sort of patients who are recruited to a study like Evolve, all have a problem with PTH that seem to be too high. Many of them calcium will be too high, and in many of them phosphorus will be too high as well. And we know that cinacalcet is extremely good at making those numbers better. So, and we know that it doesn't do much else as far as we're aware. So it's quite a clean probe in that sense. It's much better than vitamin D or calcitriol in that sense, but calcitriol moves phosphate the wrong way rather than the right way. So it's not such a good probe as cinacalcet. And so the Evolve study, which was done largely, of course, big company, commercial outfit, very expensive study. They did this study in the hope, amongst other things, that we would identify a major indication of cinacalcet as a drug that could prolong life in dialysis. And that's obviously very important, but there was a lot of curiosity around as well, just from the scientific aspect, as to whether or not moving these numbers in the right direction would translate to the predicted improvement in outcomes. And I won't go through the study in detail. You know, broadly speaking, the design is a placebo-controlled study, taking patients with moderate and moderately severe hyperparathyroidism on hemodialysis. Big study, 1,900 in each group. So this is, and all done to a good standard. This should have been the definitive study. And as you know, the primary analysis on an intention to treat basis, which is the way the study was set up, predefined, showed no difference in the composite endpoint. It showed a hint of a difference at various time points along the way, but bottom line, no difference. Therefore, negative study. But there were a number of major problems that emerged during the conduct of this study that had not been foreseen. One of them was that it turned out that the randomization process, which was randomizing nearly 4,000 patients altogether, actually ended up with two groups that weren't quite matched, which is very, very surprising to me. I was absolutely flabbergasted at the fact that they were mismatched on the basis of age by nearly a year's difference between the two groups. How can that happen? But it did happen, and apparently there's about an 8% chance, risk of that statistically, of that happening with a study of this kind. I had no idea it was that high. So that was a confound. And the age difference was one that would favour the placebo group, not the cinacalcet group. So essentially it was giving cinacalcet a slightly bigger hill to climb